Well, thank you again for having me. It's a pleasure. As Dr. Vreeland said, I've had the pleasure of working with him and Dr. Clifton, and we keep in touch. And this is a great way to keep that extension going. So, again, very honored to come talk to you guys. Today, we'll be talking a little bit about pheochromocytomas and paragangliomas, which tends to be a good size of practice that I do at Anderson. I have no disclosures. Other than I grew up around the San Antonio area, so I know the Joint Base a little bit, and also Brooks Army Base. Been there a few times as my grandparents would take me to the commissary every once in a while as a kid growing up, and then more recently through the great air shows that they put on there. So we'll talk about another thing that gets the blood pumping. A little bit about pheos and paragangliomas. We'll go through the diagnosis, staging, genetic testing, surgical management, the differences that we see sometimes between pheos and paragangliomas, advanced disease cases, and then clinical challenges that we have in those advanced cases. So just in brief about pheochromocytomas and paragangliomas. So what are they? They're catecholamine secreting tumors that we are more familiar with the ones in the adrenal gland and the adrenal medulla, we call pheochromocytomas, but also the ones along the ganglion chain, we call the paragangliomas. And these are very rare tumors, but are equally distributed between males and females and occur very sporadically throughout life, and mostly in the 4th and 5th decades of life. Occasionally, we'll see someone with a familial disorder, and they may account for up to 30 or 40%. So some of the old kind of teaching of 10, 10, 10 on your pheos, where 10 may be related to familial disorder, is probably a lot higher now that we have different identified genes. And so 30 to 40%, and these typically present usually earlier in life, often less than 45 years of age. And again, they present as a pheo when they're in the adrenal medulla, and then a paraganglioma when they're outside the adrenal gland. So think of the sympathetic ganglion, and this can be anywhere in the head, neck, thorax, and abdomen. And then they can also present as distant metastasis. So again, if you think of your sympathetic and pre-aortic paraganglium, this can be various places throughout the body. What we're more familiar with are what happens around the para-aortic area that run along the aorta and around the kidneys. So you think of your around your adrenal glands, around your renal artery and veins, and down what we call the organ of Zucker condyle. But thoracic, we'll see more commonly chest paragangliomas, head, neck, and some endocrine. We'll do carotid body tumors. We're also extra adrenal paragangliomas. So why do we treat them? In many cases, these are hormonally active tumors that produce excess catecholamine surges, and we have to treat the complications of the comorbidities associated with these. These can also be locally invasive, so we try to prevent the complications of this local invasion. And they do carry a malignant potential, and so we want to prevent the development or even palliate these metastases. And how do they present? How do we treat them? And this can be variable and very unpredictable in behavior. They can be symptomatic, they can be incidental findings, or they can be discovered through screening, like in familial screening. And we have to treat them in multiple ways. Your more commonly known medical and surgical treatments, where we block catecholamine effects to prepare for surgery for definitive management, but also in the more advanced cases where we're looking at systemic therapy, targeted therapy, nuclear medicine approaches, and directed ablation. So we're often familiar with the word incidentaloma as an adrenal tumor, which is totally unexpected. And these are things that are usually found on abdominal imaging for unrelated reasons. Someone gets an abdominal scan, they found to have an adrenal mass, and that starts to work up. And it can be as much as 4% of abdominal imaging. And these are typically non-functioning adenomas. And occasionally, the more common thing that we do find if they're functional is that they develop subclinical Cushing's disease. but more commonly we're seeing pheochromocytomas as an incidentaloma. And one of my colleagues likes to coin the words of non-incidentaloma and anticipatedoma. So a non-incidentaloma is an adrenal tumor that is presenting with symptoms. So something that's prompting imaging and prompting workup and diagnosis. So we think of an aldosteronoma and something with hard to control hypertension and hypokalemia. We think of a patient presenting with a large abdominal mass and pain and Cushing's disease or Cushing syndrome as an adrenal cortical carcinoma. And pheochromocytomas, we're considering this in a patient with episodic hypertension, headaches, and palpitations. And the other word coined by him was anticipatedoma, where this is a related condition that maybe causes us to search for an adrenal tumor. So no alerting symptoms that prompt suspicion, and it's not, but this is unexpected. So think of in the staging situation where we may find an adrenal metastasis from melanoma or for lung cancer. In the cases of pheochromocytomas, we're looking for them in the cases of familial syndromes, MEN2A, VHL, and neurofibromatosis. The patient presents with medullary thyroid cancer. This is common workup where we're looking for serum metanephrines and abdominal imagings to rule out a pheochromocytoma. So to establish the diagnosis, overall, it's nice to have concordant clinical, biochemical, and radiographic findings. The clinical symptoms we're all familiar with, the classic ones, proximal hypertension, tremors, headaches, sweating, and then some of the non-typical symptoms, which can be varied and not discrete. So constipation, very commonly, skin changes, including rashes, sensitivity to light, glucose intolerance and hypoglycemia, and even psychiatric issues with anxiety or further beyond anxiety, stress disorders. I'm sorry, I'm going to move this little guy here so that you guys can see. There we go. They can also be clinically silent and incidental findings, and like we talked about, something may be found on familial testing. Often we're seeing them in clinic because they're being blamed for other comorbidities like hypertension, where someone has anxiety, hypertension, and occasional headaches, and Dr. Google tells them they have a pheochromocytoma, and they come to visit us so that we can help rule it out. The biochemical confirmation is obviously important. There's 24-hour urine metanephrines that we use, or plasma fractionated metanephrines. Both have great sensitivity and specificity to the diagnosis. Typically, we're doing plasma metanephrines as they're a little easier to obtain from the patient. They don't have to collect their urine 24 hours. But if one form doesn't really display the diagnosis and there's a high clinical suspicion, we'll obviously do the other type as well. And typically what we're looking for in this situation is a multiple fold increase above the upper limit of normal. So something 3 to 4 times greater. It should be pretty obvious. Doesn't always have to be that way, but it's nice when it is. There's a slew of different medications that can also cause false elevation in this, anywhere from TCAs, decongestants, levodopa, amphetamines, caffeine, ethanol, stress, etc. But they can often be hidden in there where you don't really think about it, and you have to kind of look closely at a patient's medications, including ADHD medications, narcolepsy medications, often will raise these levels. So what do we look for in radiographic confirmation? We're typically doing a CT of the abdomen and pelvis in what we call an adrenal phase protocol, where we're doing a non-contrasted, contrasted, and delayed washout. And typically we want to see a high attenuation on the non-contrast phase, followed by increased uptake during the contrast, and then a delayed washout, as you can see here on the screen left. One of the classic board questions is a high intensity T2 lesion on MRI is very concerning for a neuroendocrine tumor. in this case in the area of the adrenal gland of pheochromocytoma. And then we also use nuclear medicine techniques, including MIBG, PET, and now dotatate for large and non-localizing imaging. And here are just 4 examples of different presentations of pheochromocytomas. The patient on the top left, 69-year-old man, presenting with hypertension, anxiety, and palpitations. His metanephrines are 6.5, where our normal range is less than 0.5. His normetanephrines are 17, with normal less than 0.9. So you can see he had vastly elevated serum normetanephrine and metanephrines, a large left-sided hypervascular tumor, which is a very easy and straightforward diagnosis. Here on screen, top screen right, we have a 52-year-old man. He has hypertension. He has end-stage renal disease. He's on multiple medications for that. His metanephrines are less than 0.2, and his normetanephrines are 1.4, which are slightly elevated but not overtly large. He does have a hypervascular, very small left-sided lesion that was identified during his own workup of end-stage renal disease, and he had a diagnosis of pheochromocytoma. The bottom left here, a 39-year-old man, asymptomatic, maybe a little anxiety, but nothing that really shows any overt symptoms. Comes in for unrelated abdominal imaging, was found to have a left-sided hypervascular adrenal mass, underwent the biochemical evaluation, was found to have an elevated normetanephrine level. He's 39. This is mutation negative, also pheochromocytoma. And then last on the bottom right, a 22-year-old woman with known MEN2. She's had a prior right adrenalectomy. She's asymptomatic. She was lost to follow-up. Comes in with normal normetanephrines and metanephrines, but high suspicion based on her history, and it's found to have a small left-sided cystic pheochromocytoma right here. So I like to put this slide in because it's not an uncommon scenario where we get someone that's referred to us for a pheo or paraganglioma based on a cytologic diagnosis. So biopsy is not part of the diagnosis in a pheo or paraganglioma. It's always important to rule out a pheo or paraganglioma prior to biopsying any retroperitoneal mass that's hypervascular or concerning. One thing we do routinely is genetic testing, and we would consider this as part of the diagnosis. It has multiple applications to surgery. If you think of, our concern for adrenal versus extra-adrenal, it helps us with localization of tumors. It helps us determine the risk for bilateral disease and therefore extent of surgery we should do as to whether we're doing a subtotal adrenalectomy versus total adrenalectomy. It helps give us an idea of risk of malignancy and therefore how we should approach the tumor, maybe through a minimally invasive or open approach. And it also helps with risk recurrence and surveillance planning. And who should get genetic testing? They've pretty much said that everyone with a pheo or paraganglioma should. So some of the classic teaching is that it should be for young patients with a unilateral tumor, those with a positive family history, those with bilateral tumors, all paragangliomas, and then those with a family or findings suggestive of other familial disorders like, again, VHL, MEN2, and NF. So again, we think that everyone diagnosed with pheo should undergo genetic testing. And that's because up to about 30% of patients may carry a genetic mutation or hereditary syndrome, such as RET and MEN2A, VHL, and SDHB mutations. And these tend to be the larger of the groupings. RET, VHL may account for, as you see here, around 15% of the patients. It also, these studies also help Again, you can see that along this line that the frequency of malignancy is very low in these tumors, but that the frequency of bilateral tumors may be very high. If we look at SDHB mutations, something that has a higher frequency for paraganglioma, something the malignancy risk goes up. The concern for bilateral pheochromocytoma goes very low, and the risk of multiple tumors is high. And all that is very important when you take it to the clinical aspect, because how we approach a patient. So this is a patient of Dr. Vreeland's that he has referred for evaluation here. A 29-year-old woman who was diagnosed with preeclampsia during her first pregnancy. During her second pregnancy, she underwent a little bit more abdominal scanning, was found to have multiple retroperitoneal masses. On further discussion, she was found to have a suspicious family history with a grandparent with what sounded like a pheochromocytoma or paraganglioma, and workup did find elevation in her serum metanephrine and norepinephrine levels. She has this larger right adrenal mass here and a hypervascular mass behind the mesentery down along the aortic bifurcation. And radiology also questions a small left-sided adrenal tumor. And so knowing kind of all this together, the concern is, well, we have a young 29-year-old woman who has multiple tumors, may have bilateral adrenal tumors. Is this something that we undergo bilateral subtotal adrenalectomy or on the left side, so that we can try to cure any left-sided tumor that may be growing? We know from our prior slide that the risk in SDHB mutations, which she is carrying, frequency of bilateral pheochromocytomas is 0. So not saying that this couldn't be it, but our risk level goes down lower, and we're more comfortable with watching this. It's also important to know the necessity or the benefits of that genetic testing, as this is not an infrequent occurrence where we'll get a notice of denial of medical coverage from a specific carrier saying that the literature doesn't suggest that we get genetic testing because of their age or lack of bilateral tumors or family history. So it's recommended that all pheos and paragangliomas undergo surgical resection. Again, this is to correct the cardiovascular comorbidities that we're often seeing as a result of the excessive catecholamine state. And it's also to prevent any invasive or future metastatic disease. And when we think of the risk of surgery, the main things we're talking to the patients about are vascular injury, surrounding organ injury, and then events during the case. And for the surrounding organ injury, you have to think of kind of the location of the adrenal glands as being in the retroperitoneum. Think of our major abdominal bowels anterior to the organs. We have to reflect the bowels over to see the retroperitoneal area, where we have on the right side the right adrenal gland, and the main concern being the right adrenal vein going directly into the IVC. And then we always talk about associated injuries to the renal vessels as well. On the left side, the adrenal vein goes into the left renal vein, and less of concern there. So this may be before your time, but I'm sure Dr. Clifton sported a pair of Reebok pumps when he was a kid. And that's what I kind of like to think of the tumor a little bit as a bag of catecholamines that if you pump too much, then it all goes wrong. So this is something that has to be approached in a kind of a systematic fashion when we treat these. So preoperatively, we're looking to optimize any medical comorbidity that they may have. Often they can present with a hypertension, CHF, or arrhythmias, and we're using their local or one of our cardiologists to help optimize prior to surgery. They may present with diabetes as well to glucose intolerance. What we'll do is start with an alpha adrenergic blockade, and we'll start genetic testing, as that usually takes about 4 to 6 weeks to get back. And then depending on the size and concern level, staging as necessary. Intraoperatively, you want your experienced surgical and anesthetic team available. These are people that you feel comfortable with, that are able to respond quickly to any hypertensive crisis that may happen when you're manipulating the tumor. You want some form of continuous monitoring to prevent any kind of major shifts in blood pressure. And you want to make sure that you remove all the tumor, as completeness is the cure dependency is related to completeness of resection. And then we'll often make a distinction on what type of surgery we're doing. Is this something that's locally solitary, or is this metastatic? And how we approach that may differ based on patient staging. And then immediately after the surgery, you have to still watch for any hemodynamic shifts, as they may have hypotension after being on long-term alpha blockade, and suddenly they don't have the catecholamine surge to equal them out. So preoperatively, this is a very common presentation of the patient's blood pressure chart. What we'll do is give them a chart, ask them to check their check their blood pressures and heart rates 3 times a day, and every 3rd day give us a reading or an updated reading of what they've done. You see a patient will start alpha blockade typically, then their blood pressure will come pretty well normalized, and as a response, they'll start to get tachycardic, and then we'll start adding beta blockade to compensate for that. And ultimately, you could do that with either phenoxybenzone or doxycycline. I tend to choose doxycycline for multiple day application and for fast turnoff. I'll typically try to titrate to normal tension with clinical symptoms of postural hypotension kind of being one of those indicators that you've kind of gone far enough. And when they get to tachycardia, you add a little bit of beta blockade. And then throughout the whole preparation, but most importantly, right before surgery, it's very important to make sure that they're well hydrated. So ask them to keep well hydrated, eat some salty meals right before the surgery. We did participate in a larger study of 1,800 patients, international patients, in which they did look at approaches to preoperative blockade and the patient's tolerance throughout the surgery. And in this study, up to nearly 350 patients were done without alpha blockade. So you can see that there's a large variety of providers that may not block their patients. Whether these were intentional or unintentional, it's hard to know. But either way, the complication rate was low, and it kind of raises the question of the need for blockade. In most of my cases, I will still perform alpha and beta blockade, although I may not drive someone as hard to those clinical symptoms as we talked about. So the goal is to have them nicely blocked before surgery so that you can avoid any major fluctuations in blood pressure. Regardless, this tumor is going to be manipulated during surgery, so you'll see dynamic changes. One of the common board questions asked is what intraoperative agents you want available during your surgery. And as you kind of see there on the bottom left, again, you want to make sure you have some form of monitoring. You want something that'll quickly dilate your venous pressure, something that'll bring your pressure back up, something to slow your heart rate down, and an antiarrhythmic like lidocaine, and obviously IV fluids. And so as you can see on the top chart, as we're dissecting, the blood pressures kind of shoot all over the place. The patient goes over 200 at one point, and then it's almost instantaneous when you clip the adrenal vein at the red arrow that the pressures normalize completely and stay stable throughout the case. So when we're talking about principles of surgery, the goal is complete resection, and that's the only way to achieve complete cure. And this is something that should be approached very cautiously and handled very gently, because we don't want to violate the tumor capsule. And whatever approach helps you do that, it should be the appropriate approach. So you should consider the invasiveness, the size, the location, the genetics to help you decide what that approach to full resection should be, because we want to maximize the benefits of the patient and reduce any risk of complications. And it should also, be in light of the patient's staging and kind of thoughts of what adjuvant therapy will be. So here's an example of a 43-year-old man who had a history of a total thyroidectomy at age 8 in a family history of a father with history of tumors in the neck and abdomen in his 30s. He was from California, originally treated there, found in 2015 to be symptomatic from vastly elevated metanephrine, norepinephrines, and no mutation testing at the time. Had abdominal imaging, which demonstrated these bilateral adrenal tumors, 9 centimeter and 7 centimeter, respectively. He underwent a laparoscopic resection in October of 2015 with a subtotal on the right. And unfortunately, the glands were morcellated intracorporally, kind of as a spleen would be done. And obviously, there was some disruption of tumor during the operation as well, because the operative note had talked about a right diaphragmatic violation. The left gland was morcellated as well. And then the patient presents CS 3 years later, and what you see is still a large area of tumor along the right retroperitoneal bed, and then multiple spotting of areas in the left retroperitoneal bed and perinephric areas from the morcellated tumors. And unfortunately as well, he is symptomatic with elevated metanephrine, norepinephrines. So again, this had been a better approach through an open incision, something that could have prevented fracturing. Perhaps, with the morcellation had been better not done, most likely. So you can approach it again through open or minimally invasive approaches. We typically use open approaches for larger tumors, and these can be, anterior flank or posterior incisions. When you talk about anterior, we usually use a midline or an extended McFucci incision. In fellowship, we learned to do a little bit of the thoracoabdominal approach. These can be for tumors that are incorporating the diaphragm. It's a nice approach. The pictures below show a modified McFucci incision, in which the large tumor on the right that incorporates some of the right lobe and liver, and a little bit of the lateral wall of the IVC was taken out of the right retroperitoneal bed. So the surgical approaches are on the minimally invasive side can either be done transabdominal, robotic, transabdominal, posterior retroperitoneoscopic, or posterior robotic as well. All these approaches are good. They're all different and have their own kind of pros and cons. In terms of ports and patient toleration, it's typically pretty similar. When you talk about the transabdominal approach, you usually have the ability to put a few more ports in. You have a little bit of patients having to deal with intraperitoneal insufflation and some bowel recovery. And this has kind of led us to use the posterior approach a little bit more. There's this one article by Dr. Wayne, who's an endocrine surgeon in Milwaukee, who just kind of summarized thoughts to minimally invasive adrenalectomy well, and that it typically is something that we use for a small tumor, and that small number can vary according to the endocrine surgeon, but 7 or 8 centimeters is kind of a good area to consider smaller or doing things open. If it's a pheochromocytoma, that's definitely, if it's something less concerning and softer like a myolipoma, you can consider going larger than that. But typically for phaeos, we'll do a smaller tumor. Otherwise, general principles, we want to think of something that's presumed benign and non-functional. So again, just kind of a good article to briefly summarize, what we think of should be approached minimally invasive. Smaller tumors that are benign and functioning or presumed non-functioning, selected metastasis, and the technical approach and the kind of patient selection. The largest kind of decision tree thing here should be it should be surgeon experience and comfort level. We have fellows that come and learn the retroperitoneal approach. They may leave not as comfortable with it or not as pleased with it, and they do these laparoscopic transabdominally. I think it's perfectly fine. The patient does very well, and the surgery is done to completeness and safety. So it doesn't have to be one approach or the other. I think ultimately you pick what works best for you. And what we tend to do, again, is the retroperitoneal approach. Just because we agree we may see a little bit of shorter OR time, some less blood loss, less bowel interval to recovery, and then a shorter stay. But both, again, are equally safe. So if you think of a patient laying down, kind of anterior, top of the screen, and posterior on the bottom of the screen, and an adrenal mass there on the right adrenal gland. You can think of coming transabdominally, having to move the liver and bowel aside to get to that approach, or you can think of, rotating the patient over in the prone position and coming posteriorly, along the costal margin into that retroperitoneal space into a shorter area. And this is a video of a retroperitoneal approach for a right-sided tumor. And what we have done here is gone into the retroperitoneal space. What you see on screen left are the psoas muscles, and that's one of the landmarks that we described to go identify. And this is all soft retroperitoneal fat. We're bringing this fat down from the posterior margin. And you can find here, luckily, we found our golden adrenal gland in the back. And from that point, there are different approaches to it, but typically what we're looking to do is circumferentially dissect the gland. I typically start medially to address the vasculature first, and then after that, the adrenal gland tends to be surrounded by the soft retroperitoneal fat. In the case of pheochromocytomas, it can be vascular, in which we'll use an energy device to control this. But you'll often see kind of a more reactive tumor, a more reactive patient. And the next slide will show that, in which we're doing a right-sided pheochromocytoma. And it may be a little choppy here, but there's also a lot more bouncing to the patient because as we're pushing on this tumor, patient's a little bit more hemodynamically labile. Right here, we're dissecting on the backside of the IVC, where we found the right adrenal vein. The right adrenal vein will be circumferentially dissected, ligated with a clip, laparoscopic clip applier, and then divided, where the specimen will then be removed through one of our medial ports. And this move can be a little bit hairy. I think Dr. Vreeland and I were in a case where we slightly avulsed the right adrenal vein, which was easily handled with a few clips along that junction.
You mean I did
that? We won't say who did which part. Yeah. So sometimes we're not looking for complete resection. Sometimes we're looking for a subtotal adrenalectomy, and this may be in cases where there's a high risk of bilateral disease, like anemia 2 or VHL, and then either presenting concomitantly with bilateral disease or with unilateral disease and a concern in the future. And at that case, if you can, you may want to try to preserve some adrenal tissue. And so, but this should be done when there's a low likelihood of malignancy, when it's anatomically suitable, and where, again, may help the patient avoid glucocorticoid dependency for the rest of their life. The caveat to that is that you understand there's an increased risk of recurrence based on leaving behind medullary tissue, and it has to be acceptable. So this is a case, and we'll see a little bit more of the video later, of a reoperative retroperitoneal adrenalectomy on an MEN2 patient in which we resected a pheo. And you can see the normal cortex along the outside of this pheochromocytoma. The tumor is bivalve here, and so there's really no rim of normal adrenal tissue that you can save. In this tumor, we ended up taking the majority of the adrenal gland, but you can see that the pheochromocytoma comes out kind of pedunculated from the rest of the tumor, that you could take a portion of the gland and still have clean resection margin, and cortex preservation is feasible. And then this tumor, which was very large, around 6 centimeters or so, takes up the majority of gland. The recurrence risk is high. We're doing a subtotal, so a subtotal approach is not favored. And here's an example of a case of that first one. She was a 40-year-old woman with MEN2A. She had previously been diagnosed with bilateral pheos in 2005 at our institution, was treated by Dr. Evans with the total adrenalectomy on the right side and cortical sparing on the left side. The superior aspect of the gland was spared from dissection per its operative note, and preservation of venous drainage through the phrenic veins was maintained. She was on steroids for a brief time postoperatively and then returned to normal function. And she was lost for follow-up for a longer period of time, came back to see us in 2016 when she had recurrent symptoms of catecholamine excess. And when we did repeat imaging, she was found to have around a 2.8 centimeter left adrenal mass, consistent with a left-sided pheochromocytoma, as you can see here. We used both, the sagittal and coronal views to kind of help us decide, is this applicable for a subtotal approach? As you can see here, and patient has the tumor again in the left, in the yellow, and then coming off of the tumor is what appears to be normal adrenal cortex, or at least a normal portion of the gland in the red. Again, two kind of views of that normal area. And so this video is not as nice, but you can see here going the same retroperitoneal approach. Now on the left side, this is the kidney that we're dissecting free. Here you can see adrenal tissue, which is golden on the left and normal. And then you can see here kind of more screen right, middle and screen right, what the pheochromocytoma looks like, where you have that kind of flesh-colored look on top of the golden cortex. So this was circumferentially dissected free. We had still that superior drainage through a phrenic vessel and lateral collaterals. You could see the tumor apart from normal gland. So we're using the harmonic here to separate the lower pheo from what we think is normal cortex, leaving a little chunk of adrenal tissue, which isn't much, but actually in her case was able to give her some natural glucocorticoid function, and was able to preserve some of her steroid needs. And again, that's the tumor that we were looking at earlier. And you could see that we had a clean resection, and again, preserved some cortex. So if we're thinking about paragangliomas, kind of switching ships, again, think of kind of our, that initial diagram showing kind of where the periaortic chain, sympathetic chain goes down along the aorta and down the iliacs as well. And if you think of how this would look on this angiogram, these are the yellow stars are kind of where we see our adrenal glands and our pheos, and the red stars, it's very common along that aorta to see paragangliomas down at the bifurcation and down even to the into the bladder. And this is a borrowed angiogram slide. I'm sure if there's any vascular surgeons in there, they're enjoying to see the calcifications. So special considerations for paragangliomas. So these can be more variable in presentation. They can be equally as vascular as phaeos, but they're often more invasive, locally invasive. They're extraadrenal by nature, and so often they're in hard to get to locations. And they also carry a higher risk of being malignant, so kind of adding more onto it. They need to be resected completely, as there's not a good subtotal approach to this. They're less amenable to the minimally invasive approaches because of what we just discussed, and they may be multifocal in nature. So here's one example of a periaortic paraganglioma. You can see the aorta coming down. You can see the left renal vein superior to this. And then you see this hypervascular mass midway down to iliacs. This is in a patient who was normal tensive with a normal normetanephrines of 1.1, and metanephrines were in the normal range. All our genetic testing was negative. And in a paraganglioma, another point is that we'll see an elevated normetanephrine signature and usually normal metanephrines. This is a 36-year-old man who is SDHP positive. He was one of my first cases at Anderson, presented with a large left-sided periaortic mass that was found to be a paraganglioma. This was attached to mesentery. I was overlying it, but came out without any issues. He's now, I have here been 3-year recurrence-free, but now near 7-year recurrence-free. This is a 58-year-old woman who's mutation negative, found to have some decreased renal function, has a 4.6 by 3.7 centimeter right-sided periaortic mass that was incorporating the left renal vein and renal artery. You can see kind of a diminutive right kidney that when we did functional imaging, she had low function to that right gland. She underwent surgery, which was through an open approach. Here you can see the left renal vein looped around here. Here's the left renal artery, and all this is that paraganglioma along the IVC, and this is the right gonadal vein. And this is Dr. Clifton's hand. He does not remember this case, but in preparation for this, I did go back and look at the operative note, and he is listed on there. And this is the tumor resected, attached to the kidney. You feel kind of bad. You don't know if this was truly involving or whether there's a lot of peritumoral inflammation. Our pathologist was nice enough to make these nice slides. Here you see at the cut of the right renal artery and the tumor invading into it. So a nice margin by Dr. Clifton. The problem we have between in phaeos and paragangliomas is that our histology doesn't distinguish between benign and malignant disease. And malignant disease is determined by local invasion or distant metastasis. So often, when we're looking at the literature, it'll talk a lot about metastatic disease, but it also talks about recurrent disease. And you have to try to distinguish what's residual versus recurrent versus metastatic. And more recently, the nomenclature has changed from going from a malignant pheochromocytoma to now talking about either pheo or paraganglioma and metastatic pheoparaganglioma. So some of the potential risk factors that are known are patient's age, male gender, tumor size greater than 5, the tumor type is obviously paraganglioma, and mutational status with SDH positive. So to get an idea of behavior, we'll look at several small series. This is one of 192 patients from a single center in France from 1975 to 2003. Here they had 14 patients that had synchronous metastases, so 176 patients that were at risk for recurrence, of which 29 people recurred. As you can see, the breakdown between those that are sporadic and familial. They noted their 5 and 10-year risk of recurrence being 6.5 and 16%. Again, you kind of question what's recurrence versus true metastasis. But again, we found that familial disorders and extraadrenal being risk factors. This was a paper of ours back, I think, around 2010, looking at about a 40-year experience of 371 patients, in which we noted that 50% of the patients presented with delayed or metachronous metastases. So this, of these, the paragangliomas were the majority of the metastases, but there were still 25% pheo, with an overall survival that you see there is much lower in the paraganglioma, tumor size and paraganglioma being associated with the metastasis and the overall survival decrease. And of note, we did have minimal SDH testing before this time. This is a Mayo series of 272 patients that had demonstrated a similar overall survival with Mets developing at a median of 5 years, but amazingly, up to 53 years later. There's no difference here in phaeos and paragangliomas. Dr. Clifton here. Another example of a 49-year-old woman with a functional aortic cable paraganglioma is a good example of that kind of long tail that we have to potential recurrence and metastasis. Someone with a 8.6 centimeter aortic cable paraganglioma that is SDHB positive, so she has a risk factor of SDHB, of the size, and paraganglioma. She had normal surveillance. She had complete resection, normal surveillance for 2 years, and then 2 years later presents with diffuse Mets in the right retroperitoneum. That's not amenable to surgery, unfortunately. So in her, we'll have to look at we looked at other options. So the takeaway regarding metastatic pheochromocytomas and paragangliomas is that larger tumors need staging. SDHB mutations may denote a more aggressive state, and paragangliomas have a higher risk of metastasis. Minimally invasive approaches may not be appropriate and feasible in these cases. And again, resection must be total, with surveillance needing to be long-standing. This is a little bit of a different presentation in which we see this paraganglioma at the aortic bifurcation with complete incorporation of the right iliac artery and near encasement of the left iliac artery. So this is someone surgical candidate, and we're looking for a different approach. So when we're talking about metastatic phaeos and paragangliomas, often it's not considered a surgical due to the extent of disease or invasiveness, and we're looking at different goals of patient care. Are we able to resect the metastasis without any major morbidity? Are we able to treat with a different modality? Is there a difference when we're looking at this as a synchronous tumor versus a metachronous tumor? And can we improve or palliate the patient's comorbidities, their glucose, their cardiovascular disease, their number of medications? Can any of this surgical approach to debulking facilitate any adjuvant treatments like systemic, targeted, or nuclear medicine approaches? And are we improving patient survival with anything else? And there was one paper from our institution that demonstrated a possible benefit to resection with metastatic phaeos. The overall survival was about 148 months in the patients undergoing surgery versus those that did not, which was 36 months. Likewise, if we're talking about patients with synchronous metastasis, of which 53 were presented with synchronous metastasis, overall survival was increased to 85 months in patients undergoing surgery versus 36 in those that didn't. Obviously, there's a lot of selection bias here, but the authors argue that tumor burden, not excessive catecholamine secretion, is the main determinant of overall survival. So there's different treatment options for the advanced disease state. Unfortunately, none of them are great. There's only one FDA-approved therapy out of these. Now, the cytochemotoxic agents, there aren't great responders in terms of overall survival. For targeted therapy, they have used different targeted therapy agents, mostly looking at the SDHB mutation patients, but more recently a trial in cabozantinib for metastatic pheochromocytomas and paragangliomas. The one approved trial that we're talking about is the AZEDRA or MIBG, radio-labeled MIBG, which has the best response so far. If you look at these different treatment options, this is a good slide to kind of highlight the existing treatment and targets that used it, all the way from now pembrolizumab or targeted immunotherapy, and our radio-labeled isotopes. And AZEDRA is just MIBG, but it's high affinity MIBG. So if you think of down here in the blue, which regular IBG is very low affinity or very low density, and AZEDRA is very highly labeled. So this is a case where a large left-sided retroperitoneal mass was resected at an outside institution. She came back to see us. The mass is gone, but they left behind left periaortic paraganglioma and this right-sided periaortic paraganglioma. We do functional imaging with an MIBG scan. These areas lit up, as well as multiple osseous metastases. We have to decide, is this someone that would benefit from any additional surgery? And if we think of it in kind of like terms of a thyroid, where we're debulking or removing the thyroid to facilitate radioactive iodine, we remove as much as the feasible tumor we can resect with low morbidity to facilitate her AZEDRA therapy that she just got. And I'll just kind of go briefly through here since we're near the end. Surveillance, we said, like that Mayo series, can go up to 53 years where we have a recurrence. So it's important to kind of continue long-term surveillance. I typically initially did 5 years, but again, you can have a patient that comes longer. And so it's a combination of clinical, biochemical, and radiographic. Often a patient who's symptomatic preoperatively and then gets cured will be the first to notice he or she has recurrent symptoms. There's different guidelines out there. The most recent one, the European Society, suggests at least 10 years follow-up, but that those that are high risk to be offered lifetime annual follow-up. This is one of my earlier cases, 2015. A gentleman had a very small symptomatic pheochromocytoma. It was resected. He did great. His labs corrected postoperatively for a long period of time. 2019, he comes back. He has a minimal rise in his norepinephrine. 2021, I see him back, and his norepinephrine is going up. He had imaging, and it's all normal. I don't really know what to do for him. He will probably get functional imaging at some point. I don't think this is a recurrence, but unfortunately, you never know, and you have to kind of continue the long-term surveillance. So these are rare and complex tumors. Their surgical approach is dependent on what you see and stage. Ultimately, we want complete resection. It's good to approach these in a multidisciplinary fashion. Debulking and metastatic disease may facilitate some of these advanced treatment modalities, but we're always going to have to keep a close eye for recurrence and metastasis. So with that, I'll end, and thank you for your time.
Oh, that was awesome. Can we, I know we're right at time, but if you have time for a couple questions.
Yeah, absolutely.
Okay, thank you. We'll open it up to the group.
So I have one question, Paul. You may have talked to Clifton about this, but when you, what I've noticed is if I look at adrenal on the sagittal and the adrenal is like significantly lower than the superior pole of the kidney, the RP approach is going to be god awful. And so I haven't done that many of these, but I've done those robotic instead because I watched Clifton do like a 7-hour RPA one day on a big fat guy with a really low adrenal. And I was like, I don't ever want to do that. I'm just curious what your thoughts are about that. Do you have, some patients that are good RPA candidates and some you should do from anterior, or are you doing everything RPA?
Yeah, I think, again, you kind of find out what works for you based on your patient population and your comfort level. Sometimes I agree, you get this tumor that is anterior to the kidney but low down, and you go through it a posterior approach, and it's very difficult to get across the far side of the moon, the kidney, to get to where you can dissect that adrenal all the way. And you can mobilize the kidney very thoroughly along the superior and lateral margins, and that helps a lot of time. But that you can end up in a very frustrating situation that just takes a long time to kind of pull it over. When you talk about RPA approaches, sometimes, a large BMI is kind of listed as a contraindication. And it may not be so much the BMI, I would say it's probably the patient's habitus. If it's someone that has ribs sitting on a very large hips or buttocks, that may be difficult for a retroperitoneal approach. The converse, though, is that, doing a transabdominal approach, often you're dealing with someone with voluminous intra-abdominal fat and retroperitoneal fat, and it can just be almost as miserable sometimes, or I should say as challenging, because we all love a challenge. The robotic approach, Dr. Vreeland has kind of spurred it when he was there, of me looking at doing further robotic training, because a lot of our fellows do leave and they'll incorporate adrenal robotic surgery. And part of the nicety to that is that you have that reticulating wrist motion. And so getting over the kidney in those functions is very desirable. Yeah.
So are you selectively using robotic retroperitoneal? Or do you do that at all, or what are your?
Yeah, that's currently what we're looking at. So, or what we're working on. Originally, the retroperitoneal robotic was done by one of my partners multiple years ago, and one of the issues that we sometimes see with retroperitoneal approach is that if you kind of ride the lower margin of the ribs a little bit, sometimes patients get some resultant paresthesias and abdominal laxity along the anterior lower abdominal area, and sometimes paresthesias along the anterior thigh or kind of groin area. And so I think, in the early days of the robot, that was probably a lot of pressure in that area and then torquing on those ribs. And I think kind of a combination of time with the learning curve and those complications, it wasn't viewed as any more helpful. But, the modern, the more contemporary robot with kind of straighter arms and kind of all together and easier docking makes it a lot more desirable. So, we're doing the retroperitoneal robotics typically right now kind of in the learning phase. So very selective in terms of the type, and kind of holding off on pheochromocytomas, and then trying to preference left-sided tumors since you have a little bit more room for error.
Are you guys using the XI or the SP for that?
The goal is, like we talked about before, is to move to the SP.
Okay.
Because essentially what you think of in your retroperitoneal approach, when you place your ports, you're placing them in an area probably about 6 inches, wide. And so that ends up being kind of like a single access port almost. So getting to the robotic SP is the goal. And unfortunately, what happens is that I think the SP, the arms are a little bit weaker than other platforms, and so that the ability to kind of really push things aside may be a little bit harder to do.
One other question, Paul. You'd mentioned that people with metastatic pheos don't die from or I guess my question is, what do they die from? Is it just from like other cancers? They die from cachexia and local complications? Is that?
Yeah, yeah, that can be. It depends on the type. The majority of them, probably don't die from the local issues. Some of them can die from the high catecholamine burden and heart failure and things of that nature. A lot of them, it's kind of the similar things, like you're saying, things with osseous or liver metastasis eventually causing cachexia and other organ failure.
Okay. All right. Well, we want to be mindful of your time. We really, really appreciate this talk. It was outstanding.
Absolutely, it's my pleasure. Obviously, if you have any questions or interest in a fellowship program, either surgical oncology or endocrine, we're happy to touch base at any point.
Yeah, and if you if and when you come to San Antonio, please let us take you out to dinner. We would love to see you in person.
I won't say no to that.
All right, thanks.
All right, guys. Have a good day.